India's largest optometry student community, dedicated to uniting future eye care professionals across the nation and beyond, fostering collaboration, learning, and professional growth. We're truly honored to host today's session with a very special guest from the United Kingdom. It gives me great pleasure to introduce our international speaker, Ms. Rafia Hussain. She's an orthoptist at New Cross Hospital Infirmary, Wolverhampton, England. She completed her graduation in Orthoptics from the University of Sheffield, UK. Today, she'll be enlightening us on the topic Introduction of Orthoptics. We're very grateful to have her here with us, sharing her expertise and international perspective in the field of eye care. Without further delay, let us welcome Ms. Rafia Hussain to begin her presentation. Ma'am, the virtual stage is all yours.
Hi guys, so my name's Rafia Hussain. Can everyone hear me clearly? Just want to make sure that everyone can hear me clearly. So everyone can give a thumbs up if you can hear me?
I think there seems to be some issue in your audio. You're not very audible.
Can you not hear clearly? Sorry.
Sorry, is that better? Okay, thank you. Thank you very much. Sorry about that, guys. So my name's Rafia Hussain, and as Shazia introduced me, I am a newly qualified orthoptist, and I'm currently working at New Cross in the UK. I just want to do a quick introduction of myself. So I'm currently working as an orthoptist and working in different specialty clinics such as the stroke and special needs clinics, and I'm trying to build myself and build different skills at the moment. I'm currently a BIOS British Orthoptist Society member, so I don't know if many of you have heard of that because it is a British society, but I'm part of the members and part of a visibility lead. So I just want to put that out there. It's really nice to be able to express what orthoptics is on an international level. So I thought, as Asad messaged me on LinkedIn, I thought I'll give my knowledge of what orthoptics is and exactly what we do in the UK, and we'll get into the presentation now. So if anyone's got any questions or anything, please do let me know at the end of the presentation. So I'll share the screen. Bear with me. And let me know if you can't hear my voice at any point, sorry. Okay, perfect. Can everyone see that, the presentation?
Yeah, ma'am. The slide is visible. Ma'am, please start from the first slide.
Should we start from the first slide then?
Yeah, ma'am.
Okay, that's fine. So yeah, sorry about that, guys. We're going to start again, hopefully with a clearer audio. So what is orthoptics? So orthoptists are essentially experts in diagnosing and treating defects in eye movement and how the eye works together. So essentially, we look at both eyes together at the same time. And I know a lot of optometrists obviously are assessing each individual eye separately, but as orthoptists, we look at both eyes together, essentially binocular vision. So yeah, and focusing on binocular vision, eye movement issues, and the visual development of pediatric patients. We also work closely with ophthalmologists and optometrists. So I think on a daily basis, we liaise with optometrists in refraction clinics and ophthalmologists in pre and post-operative measurements for squint surgery. Okay, so what is the role of an orthoptist? So assessing and diagnosing binocular vision problems. So what I mentioned before, detecting and managing strabismus and amblyopia. Amblyopia being obviously one of the main highlights as an orthoptist. evaluating eye movement disorders. So this ranges from nystagmus, cranial nerve palsies, which essentially is divided into the third, fourth, and sixth. And within those subdivisions are different types of abnormalities, such as mechanical and myogenic issues. Also providing essential input in neuro-ophthalmology and pediatrics. So with the role of orthoptists, we've actually got a lot of extended roles and um, different areas that have developed over time. So involvement in glaucoma and medical retina clinics, as well as pre and post-operative assessment and counselling. We also contribute to low vision services, such as providing magnifiers and really counselling patients about how to deal with this low vision, school screening, as well as teaching, training, and research. So currently, um, for instance, me as a new qualified orthoptist, I've been given the opportunity for a clinical tutors training, so I can actually teach orthoptics, to students and different medical professionals. So the next slide, the impact of orthoptics. So essentially, I've subdivided this into different categories on how orthoptics can actually improve the general public. So patients, improving the quality of life. So this ranges from driving standard, education, and comfort. So with driving standard, we've got a lot of adult patients that complain obviously of double vision, and legally in the UK, they're not allowed to drive if they've got double vision. So having that talk with them, as well as dealing and managing with their symptoms. Education and comfort. So this ranges with teenage patients who often complain of double vision due to convergence insufficiency. Um, so really helping managing that through exercises, or giving them prisms, or even referring them to any other symptoms or diagnosis that they could have. Visual development and early detection, so highlighting amblyopia, high myopia, or medical opacity. So as orthoptists, because of school screening, a lot of patients get picked up earlier. So um, parents think there's a visual issue, and once an orthoptist sees them, they get um, sorry, they get seen by an optometrist or an ophthalmologist if further investigations are required. Within the healthcare system, especially within the NHS, it reduces capacity and workload. So being able to spread out the different specialties, and essentially that all optometrists don't need to see patients where they don't need to be seen, and working in a multidisciplinary team. Also within society, vision screening and early detection, as well as patient independence and being able to drive on their own without complaining to DVLA, which is a driving standard in the UK. Um, and also professional development. I think, like I mentioned before, there's a lot of extended roles, as well as the British and Irish Orthoptic Society, which is giving orthoptists a voice and the ability to specialize in different areas. And currently, I think we're trying to advocate to do refraction clinics and actually do that independently without the need of an optometrist. But that's just something that's quite new and something we're trying to advocate for. So the next slide. So in terms of the introduction to orthoptics, I know I can talk about what we do and how we impact society, but for the next couple of slides, I thought I'd give a more clinical basis of what we do and how orthoptics actually, what we do on a day-to-day basis, essentially. So I divided this into concomitant deviations and incomitant deviations. So essentially, the squint side of things are divided into these two categories. So concomitant deviations are when the angle of deviation is the same in all positions of gaze. So this is when you see your standard esotropia, exotropia, or obviously there's subdivisions within that.
but that's just what you see with concomitant deviations. So this is usually childhood squints. You can get them as an adult, but that would be age related. This is usually caused by either refractive errors, amblyopia, or it could just be idiopathic. And usually in this case, the management is glasses, patching, prisms, or surgery, depending on whether the glasses actually impact the squint itself or not. So concomitant deviation. So this is usually in adult patients. So the angle of deviation varies in different positions of gaze. And when I say positions of gazes, sorry, I mean obviously ocular movements. So when you're assessing the ocular movements, you notice that the deviation actually changes in different positions. So this is often due to nerve palsies, muscle restrictions, trauma, thyroid eye disease, and it could be myasthenia gravis, um, Graves' disease, and the list goes on. So the symptoms are usually diplopia, abnormal head posture, limited eye movements, and as I said before, the symptoms could go on. They could complain of um, different eye muscle aches, pains, and especially when looking at their case history, we look at what medication they're taking and whether they have blood pressure issues or diabetes. And in terms of this case, the management is pretty similar. It's giving prisms, a botulinum toxin, surgery, or just general observation and making sure that the symptoms don't get worse for us to intervene in any other way. So the next slide is a case study for concomitant deviations. So I just want to give a quick overall view of, especially with optometrists, if they see this type of turn, what we do as orthoptists to deal with it. So the diagnosis is infantile esotropia, and below are just the characteristics of what we'd see in clinic. So case history is a 7-month-old child who's a female and has an inward turn that was noticed by their own opticians. So usually in clinic, we get these referrals where the optometrist actually picks up the inward turn and they refer them to the orthoptist to give a clinical diagnosis and ensure that it's not a pseudo squint and it's actually a turn that's manifest. So in terms of the vision, we obviously do a gross assessment. A 7-month-old child isn't going to really tell us if they can see letters or pictures. So we either use our tests such as Cardiff acuity cards. I don't know if any of you guys have heard of that, but it's just a quick gross assessment. Fixing and following, either using a light or target for the patient to follow, just so we know that there is some visual input there, and obviously they've got red reflex and there's no medial or opacities that are visible. So we're just doing a gross assessment on that clinic. So the cover test at near and distance on this type of infantile esotropia diagnosis, you'd usually see a constant esotropia, either the left or right eye, depending on what the patient has, or it could be in both, depending on the assessment. And usually one of the characteristics of an infantile esotropia would be DVD. So you'd notice that in clinic, and that's a big factor on diagnosing this. On ocular movements, you notice an overaction of the inferior oblique muscle, as that's another characteristic of an infantile esotropia, especially because of the age. Also with BSV tests, so usually if you get confused if it's a pseudo squint or manifest squint, we usually do BSV tests, and if the patient is able to get that correct, then you know it's a pseudo squint. So it's just one of those things where we do that to, make sure that what we're seeing is correct, or checking the corneal reflections if the child's not as cooperative in clinic. So the management side of things, within our trust, we we would send this particular patient for a refraction clinic. So we'd send them straight to the optometrist on the next available appointment, for the optometrist to have a look at the back of their eye, make sure their fundus and media is nice and clear and healthy. And then they'd pick up any refractive error and issue glasses full time. And obviously, in that way, after the refractive adaptation period, which is 18 weeks, we as orthoptists will obviously get an indication, is there any amblyopia, or are they doing fine just with the glasses? And then after that, obviously monitoring the patient with the glasses on, ensuring that their vision is both equal in the right and left eye. And that would be the overall management plan of this type of deviation. So the next case study on the next slide. Yep, perfect. This is an concomitant deviation case study. So for instance, if a 58-year-old man presented with a sudden onset of horizontal diplopia, so this is quite sudden, so it was 2 days ago that they complained of it, and the double vision worsened on the right side, and there were no other associated symptoms. He also had a history of diabetes for the past 15 years. If everyone could, just looking at that case history, would you guys know what type of deviation it is, or what you think it would be? I know it's quite a broad case history. It's just what would that indication be? They're getting double vision and it's horizontal and it's worse on a particular side. Or would you want me to carry on and then give the diagnosis?
Yes, ma'am, go ahead.
Okay, perfect. Okay, so with this type of deviation, we'd usually do, obviously, first and foremost, cover test. So CT just stands for cover test. So on the cover test, I've just given obviously a fake scenario. I saw a right inward turn at near, and in the distance, the inward turn increased. So it was much larger in the distance, the squint. Also on observation, they had a small abnormal head turn and the face was turning towards the right. So essentially, the head turn is the patient's way of compensating for the inward turn. And also on ocular movements, I saw a small right lateral rectus palsy. So that means the lateral rectus on the right eye is restricted, and that could vary to different levels of restriction. So it could have been a restriction that couldn't go past the midline, so they literally can't move their eye to the right side, or they can move it to the right side and there's a -2 restriction. So with these types of deviations, it can vary with patient to patient. Also, I've just written the measurements that I got off the patient. So for near, I've got an 18 prism diopter, and in the distance 25, and that just reflects my cover test on my observations of, it being increased in the distance. So management wise, I joined the double vision with a 16 prism diopter Fresnel prism, and I just put on the bottom a general investigation, something else would do, just to rule out anything else. So doing a CT scan and just, sorry, did Kasim raise his hand? Would you like to ask a question? Sorry. Okay.
Continue, Rafi. We'll be taking questions later after the session
Oh,
has ended.
okay, that's fine. So here on the next slide, I've just given a better visual representation of what you'd see with a sixth cranial nerve palsy. So that was a diagnosis of that case history. So with the diagnosis, I've put it could be due to microvascular episode. So this patient might have had an episode and that caused that nerve palsy in the right eye. So as you can see, this patient looking in a primary position in the middle is looking straight ahead and their right eye is turning inwards. But when they look to the left gaze, there's no deviation. So they can, their muscles on the right medial rectus and the left lateral rectus is full. There's no restrictions. However, when you look at the right gaze, the uh, the left lateral rectus isn't moving all the way as it should be, and that's a clear indication that there's sixth cranial nerve palsy in the right eye. So over here, I just put in red what we as orthoptists do to differentially diagnose this type of turn, because obviously if you see an inward turn, you could think it's just an inward turn, it's a constant esotropia. How can I differentiate that from a nerve palsy? So what we do is lateral gaze measurements, and we get the patient, just like this picture, to look in different positions of gaze, and we measure it. And obviously if the measurement is larger in that eye, then that means that means that it's a sixth cranial nerve palsy because of the incompetency of that inward turn, if that makes sense. So on the next slide, I'm just going to go over amblyopia. And obviously, I'm sure all of you guys have heard of what amblyopia is. I'm just going to go in a bit more depth of what we as orthoptists look at in terms of the different classifications. So amblyopia, what is amblyopia? So it's a reduced visual form sense. So it's not explained by any structural abnormality of the visual pathway. So we can't physically identify what's causing this reduced vision. So it's more of an issue of wearing the patch and forcing the eye to obviously create those visual pathways in the brain. It does affect 4% of the population, so it is something that's quite common. The classification is that there's stimulus deprivation amblyopia. So that can be something where a cataract and a ptosis can actually cause that restriction or obstruction of visual input. Strabismic amblyopia. So obviously, if you see a squint in a patient, they're probably most likely going to get amblyopia in that eye. This depends if it's alternating. Obviously, if a patient can alternate the squint, that could show a clear sign that maybe their visions are the same in either eye. Or if they have a outward turn, an intermittent distance exotropia, sometimes, or due to studies, it shows that they will less likely have amblyopia. And that's just something where we've picked up in clinic. We've not noticed patients that have distance exotropia and amblyopia at the same time. Anyways, anisometropia amblyopia. So this would be more with refractive errors and the difference in refractive errors between the eye. Meridional amblyopia, so uncorrected astigmatism. Ametropic amblyopia, so if you've just got high refractive errors in either eye, usually they do tend to get amblyopia. And occlusion amblyopia, so this is when excessive patching is done. So in a bit, I'm just going to explain how we counteract that through using a Spicer bar. So I don't know if many of you are aware of what the Spicer bar does. So we'll explain that in a second. So on the next slide, so I'm just going to explain about the importance of early detection and the impact of patching treatment. So the importance is that the visual system is very plastic, or plasticity, before 6 years of age, and this is the critical period. So visual development after the ages of 7 to 12. So I'm just giving a bit broad range due to the studies online. So after the ages of 7 to 12, visual development does stop, and therefore patching won't do the job that it needs to be doing. So early detection is a must with this type of management. So obviously early intervention means that greater recovery is possible for any pediatric patient, and it prevents long-term monocular vision loss. So in clinic, I've seen a lot of patients that are maybe in their teenage years being referred by their own opticians because their reduced vision wasn't picked up earlier enough. And obviously, having that conversation with the parents that we can't do much because they're fully developed and putting a patch on won't do much. It's not nice. So we're trying to advocate and get more patients um, in clinic as soon as possible with any eye related issues. So what are the short-term impacts of patching treatment? So it improves the visual acuity in the amblyopic eye. It enhances binocular vision and stereopsis, and it improves school performance and coordination. I think with obviously patching is going to help vision and improve the visual aspect, but there's a binocular aspect that we as orthoptists and as healthcare practitioners should think about. So if we help that amblyopic eye, we're actually helping them to see 3D vision and ensure that their binocular vision is actually um, intact in their early years, and also improvement in schools. So if the patient is able to see, that's definitely going to reflect their behavior in school and their ability to learn and want to learn. So that just correlates a lot with vision. Long-term impacts is it reduces lifetime risk of severe vision loss. So if their good eye is damaged, then that means they can't do a lot of things with the eye that's reduced, i.e. the amblyopic eye. So ensuring that both eyes are at a good level. So if one does deteriorate or they get into an accident, that they can still use the other eye. Increased independency. So this is a big factor in driving, in career opportunities, in being able to, you know, do whatever they want without their vision being an impactful disadvantage, and improving psychosocial outcomes. So a lot of vision issues can be associated with psychosocial issues and the ability to be confident within themselves as well. So the next slide, I'm just going to explain what the Spicer bar is. So this is a tool that is really impactful in using in for orthoptists for detection of whether patching should be done on much more older children. So 7 to 12 years of age, we use this tool. So the purpose is to quantify the density of suppression in patients with strabismus or amblyopia, and to help assess the risk of intractable diplopia before amblyopia treatment. So what we tend to do is use a Spicer bar if we get a patient that's complaining of reduced vision and they're at an older age where double vision is probably most likely. So the technique is a series of progressively darker filters, grading from light to dark. So over here on the bottom, um, I've just got an image of the Spicer bar. So it's ranging from white at the top, and then it's got a red filter in the middle, and then dark filter on the bottom. So what happens is it's held in front of the fixating the dominant eye while the patient views the light or fixation target. So you can use a pen torch or target. Well, we use pen torches, and you pop the filter bar over the normal or non-amblyopic eye, and then the filters are swapped until the suppressed, so that's a non-fixing eye, takes up fixation. So we're trying to see whether the amblyopic eye is not densely suppressed for us to start patching. So the filter number at this switch point is known as the suppression density core. So when I say the filter number, I mean on the actual bar itself, it's got numbers that indicate the suppression level. And if it's below a certain level, then we wouldn't really give them patching because of potential diplopia. So what are the properties? Lower numbers, weak suppression, high risk of diplopia. So if we get numbers less than 7, we won't do any patching. Higher numbers, so the darker filters, equals strong suppression and safer use of occlusion therapy. So this helps to determine if amblyopia treatment, i.e. patching, is safe and acceptable, especially in children from 7 to 12 years of age or above. And the next slide. So I'm just going to give a quick summary of why orthoptics matters. So early detection of vision problems, I think that's a key issue, and that's what I've been highlighting throughout the PowerPoint slides. Key role in pediatric eye care, stroke and brain injury services, and it bridges the gap between medical, optical and rehabilitative eye care, and it's a unique profession combining both science, problem solving and patient care. So the next slide. So that's the end of the PowerPoint slide. I just want to say thanks for everyone who joined and was really patient in me trying to fix the voice issue. Sorry about that, guys, again. But yeah, if you've got any questions, I'm probably going to answer them now. And
Thank you so much, Rafia. What an amazing session it was. So now we'll be taking questions. If you all have any, please drop them down in the chat box. I think we have a first question here. The question is atropine a good alternative treatment to patching for amblyopia?
yeah, so I know I didn't mention that in the slides, but there's studies to show that atropine and patching, are at the same level. So in clinic, as orthoptists, we always give them both the options. So we tell them, do you want to put drops in the weekend, or would you like to put a patch on every day? And it depends on what the parents want. Or if the patient's uncooperative and we know they're not going to wear the patches every day, then we tend to advocate for the atropine drops if that's a case of compliance.
There's another question. What activities should child do when wearing the patch or using eye drops?
That's a really good question, because I tend to say if you're doing, coloring or any close work activity, that's the best way to stimulate the eye. So obviously, if you're patching the eye and you're using the eye to read a book, to color, to draw, I don't know, whatever the kid's doing, whatever activity, that will really stimulate those visual pathways to the brain. Or if they're quite uncooperative, I tend to say if you want to watch TV or playing outside, then wearing the patch, doing something with the eye essentially as much as possible.
Another question is, how can I improve treatment success for child?
Sorry, could you repeat that again?
How can I improve treatment success for child?
I think that's a compliance issue. So really trying to motivate the kids. So that's we have lots of posters and stickers and stuff to just increase compliance, and also advocating with the parents. So giving them leaflets, teaching the parents that if they don't try to push the child to wear the patches or the glasses, then what will happen long term wise, their vision won't be developed. They'll struggle in life in general. So really trying to get the parents to understand the impact that will occur if their child doesn't comply, and that might help the child to wear it more often than not.
Another is, if you can tell us
خطوة.
Fatma, if you'll please mute your mic.
Maria, Roa.
Okay, so we have another question. If you can please tell us how a complete orthoptic evolution goes on.
What do you mean by evolution? Like, as in career?
The testing, orthoptic testing.
Oh, do you want me to explain what we do when they come in?
Yeah.
So obviously, case history, get to know the child and the patient, what's going on, to just give me an indication of what tests to do. So usually I start off with case history, like I mentioned. Then I would go straight in. It depends on the child. If I know the child's not cooperative, like you can tell in clinic, if they're running about, I would straight away go into a plus optics machine. I don't know if you guys know, I'm sure you guys are aware of it. So what it is it's a machine where it takes a picture of your eyes and it gives a rough estimate of the refractive correction of the eye. So I tend to quickly take a picture of the patient's eye. And if there's a big refractive difference between the eyes, I know that, okay, the right eye has probably got an inward turn or an outward turn, like the referral is saying. So once I've got that picture and the estimate of the refractive error, I then tend to go straight into the cover test. I want to make sure that this child has a manifest squint and it's not something that's a pseudo squint. So once I've done the cover test, I'd go straight into measurements if they've got a manifest squint. If they don't have a manifest squint and it just looks like the epicanthal folds are looking like it's an inward turn, I would test their BSV. So that would be stereopsis, so Frisbee test, a Lang test, or their sensory and motor fusion. So just testing those aspects. And if they're able to meet them and overcome the sensory and motor aspect, I would then speak to the parent about the outcome and the pathway. If they have manifest squint, we refer them on to refraction clinic with optometrists. And if they don't have a manifest squint, we tend to see them one more time just to make sure that what we saw was correct. And then we discharge them if there's nothing going on.
Okay. Okay, so the next one is, how does the specialist know the child need glasses?
So so what we tend to do is we have a vision screening specialist clinic. So what happens is orthoptists go to school and they do a vision test. And if the child, obviously, there is a possibility of the child just not cooperating. That can be a possibility. And it's just one of those things where we just have to take into account wherever they tell us. We do vision screenings, also the GP. Sometimes if the GP picks up something like an abnormal red reflex, if they pick up the patient or the parents complaining of reduced vision, they refer them to the orthoptist. And especially with the optometrist, they pick up a lot of things. So if they pick up high refractive errors, really high, such as +5, +6 and above, then they'll refer to the orthoptics to make sure that there's no amblyopia or high astigmatism. Yeah.
All right. So the next one is, how long hours should we tell the kids to do patching while they're doing their vision therapies?
So this depends on different types of vision. So if a child has 0.3 to 0.7 on the visual acuity chart, then we tend to say 2 hours of patching. However, if they have 0.7 and above, we say 6 hours patching. So these are the I'm backing up from the studies that we've done in the UK. So if they've got on the vision screen 0.3 to 0.7, it's 2 hours of patching. And if they got 0.7 and above, it's 6 hours of patching. However, you can give the parents a range of hours if you feel as though they're not going to comply. So obviously, I'm not going to say 2 hours for every patient because you can tell when the patient is going to listen or not. So I tend to say 2 to 4 hours if the patient isn't compliant. And if they're compliant, I will just say 2 hours. So obviously, I've given you the study, but it depends on what type of patient you have.
Okay. So we have a next one, how to find the dominant eye in case of equal magnitude of alternating squint.
So what you do is corneal reflections. So if you get the pen torch and just put them on their eyes, you'll look at the corneal reflections. Obviously, if they've got an inward turn, the corneal reflection will be temporal. If they've got an outward turn, the corneal reflection will be nasal. So when you've done the corneal reflections, you can tell which one the dominant eye is. Also, using a target. So if you use a target, you can tell which eye is the dominant one because the one that's manifest will be more inwards or outwards. And also convergence. I think that's a really good test to test which one's the manifest eye because it can be quite confusing if it's alternating. So putting a target up to the nose and you can tell which one's turning inwards or manifest more often.
We have another question. Can orthoptics correct eye misalignment without surgery?
So that depends on what type of inward turn we're talking about. So obviously with manifest squints that are large, we can't do that. That's only corrected with surgery. However, if they've got a more of a heterophoria. So if they've got a decompensating squint, which means they can be so they're straight most of the time, but if they're compensating and they're complaining of double vision, we can improve it through exercises. So you could give them stereograms or dot cards. I don't know if you guys are aware of the different therapeutic management plans for that, but it's basically convergence exercises. So using a pen up to the nose and making sure that they exercise those. And we can only correct those individuals with proven BSV. So if they can't prove BSV, we can't correct it in clinic. That can only be done through surgery.
Okay, all right. There's another question. If you can share with us some methods to increase the vision for children.
So the only methods would be wearing the glasses for the refractive adaptation, so 18 weeks, and then the patching treatment. So patching or the drops, atropine. That's the only way we can improve vision on a visual basis. There's no other treatment. So what does that, sorry, is there, could you repeat that question one more time, just so I know that I'm answering it right, sorry.
The question was that if you can share with us some methods by which we can increase the vision in children. It is a generalized question. There were no specifications.
So yeah, I think glasses and patching are the only ways that vision can actually be improved. And obviously, I think compliance is the only way we can get that child to improve their vision. And obviously, the fundal reflex, is another way to detect for early detection. So obviously, as optometrists or orthoptists, if you're in clinic and on the referral, it doesn't say red reflex is clear, we tend to check the red reflexes and just to ensure that there's no medial opacities or nothing that the GP, optometrist, or anyone else that referred this child has missed. So just making sure we've done all these investigations before discharging or doing any other management plans.
All right. We have, I think, the last question. The child's glasses look very strong. Is this normal? The child say they see better without glasses or glasses seem misty. And in that case, what should the practitioner do?
Yeah, so that's quite funny because I had this exact same all this for the glasses. So if so when optometrists check the refractive area, give the full prescription, and that's normal.
Rafia, I think we are having issues with your audio again.
Can you hear now?
Yeah.
Okay, sorry about that. So obviously we call this fogging of the glasses. So what optometrists tend to do is give the full refractive correction to the child, which is totally normal. But with some children, this can cause fogging or blurriness or misty, like you said. So what we tend to do is we do a prism test where essentially we reduce the prescription until the visions are at a good level, if that makes sense. So what we do is on trial frames, we put prisms and we reduce it down to 0.5 diopters. So we reduce it down until their vision is at a good level, if that makes sense. So if they've got +5, I'd reduce it down to plus 4.25 or +4 or +4.5, whichever way you'd like to go. And you reduce it down until the vision in the right eye and left eye separately is 6.6 or, the best level it can get at. So, and then once we've done that, we write a letter to the optometrist and they can get it changed. They get it changed to the level that we found in clinic. So yeah, there's a lot of patients that come in and say, I don't like wearing my glasses. And sometimes it can be true. So making sure that we do that prism test to check.
Okay, all right. So if anyone has any other questions, they can ask with. Okay, yeah, we do. What type of exercise is recommended for a patient who is 25-year-old, has convergence insufficiency with accommodation insufficiency?
So it just depends because obviously they've got these two diagnoses. Have they been given the full refraction in terms of the accommodative side of things. So making sure that they're given the best refractive error for the glasses. So obviously they are an adult, so they probably are wearing the best glasses. And then in terms of the convergence side of things, we tend to give them, we start with the push pen push pen. Sorry, I don't know which way it is, but the pen exercises. Yeah, so get the pen, look at the tip of the pen, and I think explaining how to do the tests are really important, because a lot of patients just come in and say, I've been looking at a pen and pushing it forward. They're not exercising their eyes. They're not understanding the actual basis of how to do the tests. So having maybe a leaflet to explain how to do the test might help them. So there's a pen push exercise, there's a dot card. So we have a card with a long list of different dots, and the patient has to focus on each dot and make it clear and single. We've got a stereogram test, so it's really pushing their 3D vision to fuse two images and make it a 3D image. I don't know if you guys have access to that. I can send. So it's called a stereo cat card.
I don't think we have any knowledge.
So we've got three tests, which is the dot card, the push pen test, and the stereo cat card. So if you can research that, you can literally see on Google Images what we use, and it just helps with the convergence side of things.
Okay, all right. We have one last question. If can we keep full correction from the starting of the treatment?
Is this for pediatric patients or children?
Yeah, I think so. It's not specified actually.
So yeah, I would give, not I would, but our optometrists give the full refractive, pediatric, thank you. So we give the full refractive correction in our clinic, because obviously every optometrist is different. I know some clinics don't give the full amount, some do. So it depends on which studies you focus on or which ones you think are more appropriate. But in our clinic, we give the full refractive correction and ensure that they're wearing the full refractive correction rather than something that's not as clear. So we'd rather do that and change it as we assess the child.
Okay, there are no more questions. Now we have a career guidance question. What to do after BSc optometry to get an orthoptic specialist training, if you have any idea?
Because in the UK, what we tend to do is we do like a whole degree. You have to do the degree to actually specialize in orthoptics. So if someone had an optometry degree, they'd have to go back to uni and do orthoptics. So I'm not sure how it is in India. I'm not sure how the system is, but because obviously you're optometrist, it might be that you won't have to do the full year. I'm not sure. Sorry, the career wise. Sorry about that, because it's different in the, and I don't want to give wrong information.
It's okay. It's okay. It's all right. So as we come to the end of today's international webinar, I would like to sincerely thank our speaker, Ms. Rafia Hussain, for sharing her valuable knowledge and giving us clear introduction to the world of orthoptics. A big thank you goes to all the participants who joined us from different countries and made this event extremely successful. On behalf of OPTOBHARAT, we hope you found today's session enriching and look forward to seeing you in our future webinars. Thank you so much and have a wonderful day.
Thank you. Thanks for having me. Thanks.
You're welcome.